we move on to the next section, improving daily clinical practice in upper GI disease. I would like to introduce our moderator, Professor Ratha-korn Vilaichone. Currently, Professor Vilaichone is and Chief Center of Excellence in Digestive Disease of Thammasat University, Assistant to the Sector in Academic Affairs Thammasat University, Secretary of the ASEAN Stomach and Microbiota Study Group, and Scientific Chairman, ASEAN Gastro 2022. Please join me welcoming Professor Ratha-korn Vilaichone.
Thank you so much, Professor Navapan, for a very good introduction. So we're going to move to the academic sessions in the afternoon. I believe that many of you is going to feel just like a little bit sleepy. So we have very good coffee outside. Just bring in and take that one. Right? Maybe improve your activity right now. So today we're going to have two speakers from Thailand and another one's from Vietnam. Not sure that Professor Duc, you are in the online.
Good afternoon, Professor Ratha-korn.
Hello.
Good afternoon, everybody.
Thank you
for inviting me to join this important session.
Long time no see. How it's going? How about the situations in Vietnam right now? So COVID infections is getting better?
Okay, it's getting better and under control. We have some. We still have some new cases, but most of the cases are not severe. So very lucky.
Thank you so much for joining today. So very first we go to Professor Monthira. Professor Monthira is the Associate Professor of Medicine in Sirat Hospital. She is also an international speaker in many aspects of GI functional disease. Today, Professor Monthira can let us know more about the new mucoprotective agents in our clinical practice. Please welcome Professor Monthira.
Good afternoon, everyone, and thanks, Professor Ratha-korn, for the kind introduction. And also hello to Professor Duc from Vietnam. My talk today is about the one and the friendly, the new mucoprotective drugs. Okay, so the content today will be NSAID-associated GI toxicity, if any effectiveness and safety strategy for the prevention. And we know that PPI has been used for a long while in NSAID gastroenteropathy. And is it good for small bowel as well? And we are going to mucoprotective agent, is it beyond to PPI? And our sponsor today is ursogladine, who we are going to talk about mechanism of action and clinical studies about ursogladine. So the NSAID-associated GI toxicity, we know that we have used PPI for prevention and treatment of NSAID-associated GI toxicity for a long time. But we don't know which combination is good. So this meta-analysis, which conducted and published in 2016, was conducted to evaluate the comparative effectiveness of clinical strategies to preventing GI toxicity induced by NSAIDs. And they bring studies from many major databases and take only randomized control trials to compare the risk of GI adverse events in patients taking non-selective NSAIDs, selective NSAID, and plus GI gastroprotective agent, including proton pump inhibitors, H2 blocker, misoprostol, and you compare in each groups. And in the analysis, they have 82 trials, include up to 100,000 participants. And the main outcome, if you can see the upper panel, you can see that when compare between non-selective NSAIDs plus PPI versus selective COX-2 inhibitor, the result kind of comparable between these two intervention. But if you look at the lower panel, you can see that selective COX-2 inhibitors plus PPI is better than selective COX-2 inhibitors alone. So this slide summarizes the result of this meta-analysis that if you look at each intervention compared with non-selective NSAID, you can see that the combination of the selective COX-2 inhibitors plus PPI provides the best GI protection, followed by selective COX-2 inhibitors, and thirdly by non-selective NSAIDs plus PPI. So we are good with PPI, right? So what about most of the study in that meta-analysis usually conducted to look at the side effect in terms of stomach. Some of them conducted in small bowel enteropathy as well, but when PPI plus NSAID, is it aggravation of small bowel enteropathy? It has a study published in CGH in 2016 by a Japanese group, and they conduct by use have 57 healthy volunteer and did a capsule endoscopy at the initial of the study, and then give the intervention, which including celecoxib 200 milligram BID plus placebo, and compare with celecoxib BID dose plus PPI. In this case, they use rabiprazole 20 milligram per day. And then 2 weeks after that, they did EGD and capsule endoscopy again. And the result is interesting that you can see that the result, if you use PPI plus COX-2 inhibitor, the subject with small bowel injury seem to be higher than the group that have COX-2 alone. This is the instance of small bowel injury in the COX-2 compared to COX-2 plus PPI. And if you look at the site of the injury, you can see that jejunum is predominant, like this is 26% compared to 0%. And the jejunum for the ileum, it's not difference between two interventions. However, you can see that it tends to be more often that you can see the injury in the ileum in the group of PPI plus NSAID. So this is interesting that, okay, we have to use NSAID, we have to use NSAID, and we have to use PPI to protect it, right? But sometimes it might be not good for small bowel. So anything that can be used more than PPI. So we are going to look at the mucoprotective agents if it has any role for that. Sorry. This is the latest publication in Therapeutic Gastroenterology 2021. They use, this is a systematic review and meta-analysis of randomized control trial and have 4 database to compare mucoprotective. In this case, they use the abbreviation of MP to placebo, PPI H2 blocker in NSAID associated small intestinal injuries. And the main outcome in this study was mucosal integrity, mucosal breaks after treatment, mucosal injury improvement, and complete healing of mucosal break. And they recruit our 18 RCTs to look at the result. And the results show that mucoprotective medications administration prevent and decrease the number of mucosal erosion and lead to a significant lower chance of developing mucosal breaks after treatment with the odds ratio of 0.38. Mucoprotective agent also associated with a higher rate of complete healing of mucosal breaks with the OR of 5.4. So in this meta-analysis, they conclude that mucoprotective agent treatment administered with NSAID can prevent and reduce small intestinal mucosal lesions. And if you look at the study in this meta-analysis, they use many kind of comparison. For example, NSAID plus PPI, NSAID with placebo. But today I'm going to focus on the study in the box that mainly use ursoglidine. The upper 2 study was done compared to PPI, and another and lower is compared to placebo. Overall study, overall analysis, it shows benefit of mucoprotective agent. So let's learn about the mechanism of action of ursoglidine. The action of ursoglidine on the This is the chemical structure of ursoglycine, and the possible mechanism of actions of this drug is it works through the pathway of phosphodiesterase inhibition and increase cyclic AMP and activate protein kinase A. Another pathway is to induce nitric oxide, and the outcome of the treatment is to facilitation of gap junctional intercellular communication, or we can say gastric epithelial cells. Another outcome is to inhibit the superoxide generation or neutrophil, and the last one is increase gastric mucosal blood flow or blood vessels. So it's kind of helped in terms of healing and also protection of the gastric environment or GI environment. And this is the study in animals. They use mucoprotective agent, including ursoglycine, ampicillin, PG2, another two kinds of mucoprotective agent, rebamipine and teprinolone. And you can see that different dosage of ursoglycine. The higher dosage seem to have a better outcome that decreased intestinal lesion compared to control. But this is a small study, and and also in the animal. So they just give us some sense that okay, this minor change in animals maybe affect human GI as well. So next study. Similar study, they compare the effect of the drugs on the development of antral-elations induced in rats. And this is kind of control group using saline and compare with 3 kinds of mucoprotective agent in Japan, teprinolone, rebamipine, and ursoglycine. And you can see that they are decrease the lesion of at the antral area, both in hemorrhagic lesions and non-hemorrhagic and total lesions significantly. Another study is the effect of ursoglycine on antral lesions induced by alendronate. The previous slide, this induced by indomethacin and paroxetine. And this study induced the lesion by alendronate, which we are well known that is create GI side effect, right? And they, when compared between normal or a disease kind of control group and use different dosage of ursoglycine, you can see that the lesion area is decreased in ursoglycine group, and the higher dose seem to be better. And the events blue in this case, it's the way that they enhance visibility of GI integrity more clearly. Okay, and this is a microscopic photographs of the small bowel mucosa stained by PAS. PAS is to emphasize or to demonstrate the richness of the small intestine and compared to normal mucosa and mucosa treated with indomethacin or a kind of NSAID. And the third or the C photo is the mucosa treated with indomethacin plus ursoglycine. You can see that the area of PS stain positive is quite similar from photo A and photo C. So it's give us some sense that ursoglycine might help to enrich the GI integrity. Okay, let's move to clinical studies. The first study is ursoglycine is to improve small injuries in regular user of NSAIDs. Sometimes we could not stop using NSAID in some patients, right? So in this study, they have 41 cases, which the baseline taking conventional NSAID more than 4 weeks, and have PPI, H2 blocker, rebamipine, teprinolone, or sulfacorn as a control. And they gave ursoglycine 4 milligram per day and compared to control this for intervention and look at the outcome, which is percent mucosal injury improvement at 4 weeks. The way that they measure the GI lesion is to do capsule endoscopy at the initial of the study. At the end of the study is 4 weeks. And this is demographic data. So it's various kind of NSAID and various kinds of control. And they sum up these control together and compare with ursoglycine alone. And the results show that if you look at the endpoint state that the primary endpoint is the improvement rate of small intestinal mucosal injury at the post-treatment CE after 1 month of treatment. And the mucosal injury improvement defined as at least one of the total number of all SI mucosal injuries was reduced from the baseline of CE. And this is the graph to show the improvement rate compare between ursogladine and control, which is a sum up of many interventions, right? In this case, total is better in ursogladine group, but for the erosive and ulcerative lesion was not significant difference, although ursogladine seemed to have a better outcome. This is another graph to show the changes in number of lesions post-treatment. And you can see that ursogladine gave improvement in terms of mucosal lesion, but for the control, it has both improvement and deterioration. I think mucoprotective agent other is also good, but this might be the effect of another one, like a PPI or H2 blocker. So in conclusion, in this study, they said that ursogladine muriate was effective for reducing NSAID-induced small intestinal mucosal injury. Let's move to another study. It's a long-term PPI compared to ursogladine on NSAID-induced small intestinal lesion in healthy control. So they would like to assess time course changes of small intestinal lesion during long-term treatment with diclofenac sodium plus omeprazole and the effects of ursogladine on such lesions. So what they did is that they recruit 37 cases of healthy volunteers and gave the intervention. So they have 3 groups here. Group A is PPI plus NSAID. Group B is PPI plus ursogladine. And group C is diclofenac plus omeprazole. So group C is act as the control group and only 5 cases in this one. And the group A, they use the same as C, right? But at the 6th week of the intervention, they gave ursogladine. So this group represents the treatment group. For the group B, as they are initiate ursogladine at the same time as diclofenac. So this group is the arm to represent the prevention group. Okay. And this is the picture to example of the lesion in this study, like a bleeding, mucosal break, and related lesions, which everyone know about that already. And this is the demographic data between the groups, which is not very different. And look at the result. Remember that group A is a group of treatment, right? Initially, group A is the triangle here. You can see at the 2nd weeks of treatment of NSAID plus PPI seem to be increase of the lesion compared to NSAID plus ursogladine significantly. And after that, it seemed to be a little bit better. I mean, at the 6th week, the number of lesions is decreased, but it's still higher than the B group or prevention group significantly. However, after the treatment, it seemed to be that this group is better after giving ursogladine at 6 weeks compared to group C, which is have only PPI plus NSAID. Totally, it's stable in terms of number of lesions. So you can see that at the 2nd week. So in this study, I think usually humans have their own mechanism to heal the lesion or protect the lesion. So initially, even if you have lesion, you can be better or you have some healing of the lesion. But if you have to take it more than 6 weeks or 10 weeks or a years, we don't know what would happen. So if you intervene with ursogladine, it seems to be helpful in terms of GI protection in this case. This is small bowel. So I know that the number of lesions is very subtle changes, like a 0.5 and 1 and 1.5, but I don't know if this is just give you some picture of the mechanism of the medications. Okay, let's move to another study. This is ursogladine compared to PPI on NSAID-induced esophagitis, peptic ulcer, small intestinal lesion in Hilsman. So previous two study, I'm talking about small intestinal lesion, but in this study, they would like to show if other side of GI also have a benefit from ursocladin or not. So they would like to compare the efficacy of ursocladin and PPI in preventing NSAID-induced esophagitis, peptic ulcers, and small intestinal mucosal injury in healthy subjects. This is a prospective randomized study and have a healthy volunteer, 32 cases, intervention with PPI plus ursocladin, and compare with NSAID plus PPI. And the outcome is to look at the esophagitis and peptic ulcer evaluated by EGD and small intestinal injuries by capsule endoscopy. They also measure indirect evidence of GI injury, including fecal calprotectin and fecal occult blood tests. And the group 1 is ursocladin group plus NSAID. Group O is omeprazole or PPI plus NSAID. And compare between week 1 and week 2. And here are the results. This is the characteristic at baseline of two groups, which is not difference between, any parameter. But when you look at the outcome at second week, compare between ursocladin group baseline and post-treatment is also not different. But in the omeprazole group, it seemed to increase Lanza score, which indicated gastritis, right? And when you look at the small bowel, this is the mean mucosal breaks per subject at post-treatment by capsule endoscopy. You can see compare between ursocladin. This is quite flat, not very changes that much. But in PPI plus NSAID, it seems to be a little bit higher. And this is significant statistically, which is present in right table here. That omeprazole group, PPI plus NSAID group increased the number of mucosal breaks significantly compared to the baseline, while the ursocladin group is not different. And this is indirect evidence to see the mucosal injury is calprotectin, also similar that ursocladin group is kind of stable, but in PPI group, it increased calprotectin at 2 weeks. And this is the occult blood. If you see the exacerbation in ursocladin is around 25% by eyeball, and this is up to 80% by eyeball in PPI group. So in this study, they conclude that ursocladin did significantly inhibit lesion development in the small intestine compared with PPI. Next study is ursocladin also accelerates GU healing after treatment for H. pylori. This to verify the efficacy of treatment with ursocladin between the termination and assessment of the treatment for eradicating H. pylori in double-blind study. So basically, they include up to 300 cases of gastric ulcer, which the size is more than 5 millimeter in HP positive, and then they gave intervention with eradication. And after that, they gave ursocladin and compare with placebo. The dose that they use is 4 milligrams per day, and the outcome to see percent of gastric ulcer healing rate. The result is quite interesting in my opinion. I don't have, I don't know if any mechanism about that, but it's quite interesting that if you look at the IM is ursocladin maleate and P is placebo group, you can see that in patient healing rate in 2 treatment groups in the full analysis set is ursocladin is better, and also in case of eradication failure, also is better in group of ursocladin. And the side effect between the 2 groups, because this is a quite big study, up to 300 cases, so around 10% of the side effect of the both groups. Another study in GU healing I mean, last study, they compare ursogladin and placebo, which is not fair. I mean, it's not very fair because it's okay to look at the to look at the one intervention with placebo, but this one is to compare with acid suppression, right? Because you have ulcer, but ulcer is not that big. But anyway, they had single TU, and the size is more than 5 millimeter in diameter, and the OR test positive for H. pylori and be eradicated before randomization into the group 1 is ursogladin 4 milligram per day, and group F is famotidine 40 milligram per day. And this is the baseline characteristic, which is similar between two groups. And this one is interesting that overall treatment eradication rate doesn't different. But when you look at the smoking status and drinking status, it came to be interesting, I think, because if you look at the result of F, I mean group F, right, in smoking positive compared to smoking positive in ursogladin, it seemed to be that smoking positive in famotidine is not very good in terms of healing rate, significantly compared to the ursogladin group. But if you look at the drinking status, in ursogladin group, it doesn't matter if you drink or not drink. The result is similar, right? But in famotidine group, you can see that the people who drank or drink a lot, it will be the result is not that good compared to people who didn't drink. So this is interesting to me. Okay, and like I said, that the healing rates between groups is not very different between famotidine and ursogladin, but it seemed to be that the findings suggest that ursogladin is more beneficial than famotidine in patients who drink alcohol and smoke. So what I think is that it's possibly because about the, you know, like I don't know if it's a gut microbiota or the status of acidity in the stomach, it's an effect, and the smoking status and drinking alcohol also change the microbiota and also the acidity in the stomach as well. I don't know if this can explain the result or not, but for the ursogladin, it seems to be neutral in that cases. So I don't know, we need more data to support this. Anyway, so this is the dosage and administration of the dosage of ursogladin. If you are interested to use it, you can use it in gastric ulcer. You can use it in small bowel injury, and both in prevention and also for the healing. And the dose that you will use is 4 milligram once a day or twice a day. And you can take it before or after meal, and you can take it anytime. Okay, this is end of my talk today. Thank you.
Thank you so much, Professor Monthira, for your excellent talk. So we're gonna take the Q&A sessions at the end. And next, we're gonna have Professor Duc from Vietnam. Professor Duc is the Vice President of the Vietnam's Association of Gastroenterology and the Secretary General of the Vietnam Federations for the Digestive Endoscopy. Professor Duc is also international leaders in Helicobacter pylori infections. Professor Duc, please.
Thank you, Professor Ratha-korn, for your kind introduction. I'm very sorry for not joining you on site because of some the important duty at my my faculty. But I would like to thank the organizer and Professor Ratha-korn, Professor Vadocha for inviting me to join this meeting. So I would like to share my slide now. Okay. So my talk today will be on the H. pylori eradication in ASEAN. And as you know that we have a very high prevalence of H. pylori infection in our region. And this slide to show that this is the prevalence of H. pylori infection in our region. And the infection rate is not comparable between among countries. And you see here that I would like to show that okay, it's very high in Vietnam, in Myanmar, and in Indonesia. But in this slide, it's also show you that the gastric cancer prevalence is not parallel to H. pylori infection in our countries, especially high in Vietnam, but it's still very low in Laos, even though we have a comparative rate of H. pylori infection. And it's not just the gastric cancer that the H. pylori infection rate in related upper gastrointestinal disorder, I mean the benign disorder, are also significant different. And as you see here that it's for non-ulcer disorder, dyspepsia or gastritis, it may be as high as 90% in Laos and maybe moderate in Indonesia, and in Vietnam, it may be very low in Myanmar. And again, for duodenal ulcer or gastric ulcer, it may be high at 90% in Cambodia, in Indonesia, and in Vietnam, but maybe as low as 1/3 in the Philippines. It may be because of the equipment or the test that we use to diagnose the H. pylori infection, but it may be also other host factor that I think that it may be a very good change for all of us here to collaborate with each other to investigate the interaction between H. pylori and host factor in our region. So it's very important to consider about the pattern of H. pylori antibiotic resistance, and this data was reported by Professor Vilaichone before 2015. And you see here that amoxicillin is was very slow before 2015, except for Indonesia. But we already have a high rate of clarithromycin, especially in Cambodia, in Vietnam, in Indonesia. We have almost no resistance of tetracycline in our region, but some increase of levofloxacin, and especially in Laos and in Singapore and in Vietnam. So it's very important to see what happened to us right now. And I would like to share with you some of the information in our region. And we have some information from our countries here. And in this slide, the red color, the data in the red depicts the increased rate compared to what we see before 2015. So we see some increase, especially in Thailand and Malaysia. The two countries are now at the borderline of the H. pylori clarithromycin resistant, considered high region. And we see some increase in Myanmar, especially even higher in Vietnam. For amoxicillin, still low, but still we see some alarming feature there in Vietnam. Is the levofloxacin emergent increasing, especially in Myanmar and in Vietnam. But for tetracycline, we still see here that maybe still very low number or even no resistance to this antibiotics. So it's not just the drug resistance, but the emergence of multi-drug resistance is also very important in our region. And this is the systematic review recently published in Antibiotics, and it's included 15 studies, mostly from Thailand, from Vietnam, and from Malaysia, but we also have some contributed data from Cambodia, Indonesia, and Laos. And it shows that in this slide, you see here the data in Thailand. You see we have 5 studies, 3 studies show no multi-drug resistance, and 2 with some resistance here. But the two Vilaichone show that this multi-drug resistance rate were reported in the mountain people and the people in the yellow triangle. So for the other region in Thailand, maybe there's a very low no multi-drug resistance. The situation in Cambodia, we see alarming finding here. Only 1 study, but about 2/4 of the patient can have a multi-drug resistance. That means at least 2 resistant to at least 2 antibiotics. And here we have 1 study from Indonesia with no multi-drug resistance, and from Laos, no. And for the Malaysia, you see here where we have 3 studies, and we have data from 2004 and 2007, only 2.4 to 0.1%, and has increased to 7.4% in 2015. And if we look at the Singaporean, You see here that with the same period like Malaysia, the patients in Singapore may have a similar findings with data with multi-drug resistance. And for Vietnam, you see alarming findings here. Already in the year 2008, you see a very high number, high proportion of patients with multi-drug resistance, and it's even higher in other studies as well. So next, I would like to tell you some of the preliminary findings of the study. It's an ongoing study on H. pylori eradication in Asian. And just before the finding, I show you the finding, I just would like to mention about the Helicobacter pylori consensus, the Bangkok consensus in our region, which was published in 2018. And in this consensus, we mentioned that we should consider the regimen based on the availability of the susceptibility testing. And if the susceptibility testing is available, then we should, based on the test, to choose the appropriate regimen with PPI and two other antibiotics, that is the triple therapy, or we call it a Taylor therapy. But because of the susceptibility testing is not available in many countries, then if you don't have the test, then we have to, based on the best locally available regimen, and we should use the drug that which resistance is rare and successful is locally reliable and cost effective. So next, I would like to share with you some of the findings of the survey. It's the ongoing survey. And at the meantime, we have 10 countries in our region to join this meeting. And I also would like to thank all the principal contributors of the Asian survey to join us and share with us the information of the real-life practice of colleagues in our region. So the first thing that we asked about our colleagues about the subspecialty, and you see here that about 60% of our colleagues are gastroenterologists, and the others are general practitioner or internal medicine. And it is the years of practice with half of the participants has at least 10 years of experience. And regarding the hospital base, then about 2/3 of the participants are government, belong to the government or the public hospital. So it's interesting to see where our colleagues find the reference for H. pylori eradication. And I separate the data into two groups. The first group for the country group 1, that means the group with high clarithromycin resistance, consists of Cambodia, Indonesia, and Vietnam. And the country group 2 for low clarithromycin resistance, consisting of the other countries. When we ask about the available of local or national guidelines within the last 5 years, you see here that significantly higher of participants in the group 1 reported that they have the local guideline. That means that the resistance is very alarming, that they need some intermediate guideline to guide the treatment. And also interesting when we asked about the international guideline that our participants refer to practice of H. pylori treatment. You see here that for the Bangkok consensus, about 1/3 of the participants use the Bangkok consensus, but much more higher in the group with group 2. So in the group 1, because of the high clarithromycin resistance, and it's very hard to eradicate H. pylori, then other international guidelines, including Maastricht, Toronto, and American College Gastroenterology Society clinical guidelines are also used more common in group 1. So we also asked about the availability facility for testing and treatment. And regarding to PCAP is the more common and more available in the group 2 country, where bismuth is more common in the group 1. And I think it's a very important area that we should consider when we develop the next guideline of the region. And about the availability of antibiotic susceptibility testing, it's more available in country group 1 compared to group 2. In group 2, we have less than half of the participants have such test for the H. pylori sensitivity testing. So when we ask about the first line regimen in real life practice, you see here that interestingly in the group 1, group 2, you see that the traditional tribal therapy was used very common, while in the group 1, our participants tend to use the PPI, amoxicillin, and levofloxacin plus or with or without bismuth. And quadruple therapy is also more common. And for the concomitant therapy and sequential therapy is more commonly prescribed in the country group 2. And regarding the duration of H. pylori eradication therapy, you see here that more participants in the country group 1 used on regimen with 14 days, while some of the participants in the group 2 used the 10-day regimen. So regarding the second line regimen in real life practice, again, there's some significant difference here. And you see here that in the group 1, people tend to use the PPI, amoxicillin, and levofloxacin with or without bismuth, while in the other group, I mean the group 2, people use the PPI, amoxicillin, and metronidazole, or we have some kind of quadruple therapy here, and it's higher than the group 1. The reason is that maybe in the group 1, it has been used as the first line regimen already. So finally, I would like to talk about some data regarding the current status of H. pylori eradication in ASEAN. And first thing, I would like to share the situation of Thailand, Singapore, and Malaysia. It is because you see here that the clarithromycin resistant day, I mean, is now in the borderline. They mean around 15. So what happened in the real life practice now? So it's a very interesting study from the real world data in a single Chulalongkorn Hospital, a single single center data to show that for the initial regimen, you see here totally they have more than 1,000 regimen. You see here the total is more than 1,200. And the most common regimen was the triple therapy with the successful rate very acceptable, more than 90%. And for the other regimen, you see sequential therapy, levofloxacin-based triple therapy, or quadruple therapy. We also have a good successful rate, but the number of regimens were much lower. And regarding the regimen used after failure of the initial regimen, that means the second choice. So again, for the triple therapy here is that the therapy used the PPI with different antibiotics and or at higher dose or longer duration, which shows that the success rate is also acceptable, nearly 90%. But for sequential therapy or other quadruple therapy, you see here that we have very low successful rate. So now we change to another country in our region, and we have some data from Professor Ang in Singapore. And in this, this is a single center retrospective clinical audit in the 2017 and 2018. And totally they have around 1,000 regimen eradication cases. And the most common regimen is also PPI, amoxicillin, and clarithromycin. And you see here that some patients were prescribed 7 days, 10 days, or 14 days. So let's see the eradication success. So this slide shows that the temporal change in clarithromycin in the blue bar and the amoxicillin resistance rate in the orange bar during 2000 up to 2014. You see here that significantly increased of clarithromycin up to 2014 now more than 17%, but for amoxicillin still very stable. And here is the eradication rate of triple therapy over the 2 decades. For the 7-day treatment of this triple therapy, you see they had the eradication of rate of 94%, which has dropped to, you see here, 7 days in 2018, dropped to 76%. But when we use the same triple therapy in 14 days, the same eradication treatment, but for longer duration. You see here with acceptable rate of eradication. So I think that is a very nice data to show that in Singapore, a country with borderline data of clarithromycin resistance, we still have a good result with tripotherapy, given that the treatment was prescribed in 14 days. It's very important to use it in 14 days. So we know that ASEAN is a dynamic region, and people can move back and forth for traveling and for working. So it's also a very interesting study in Singapore to show that the antibiotic resistant pattern and the therapeutic outcome of Helicobacter pylori infection in high migrant Singaporean and the residents in Singapore. So in this study, we show that they have 70 children, and about half of the children show some type of antibiotic resistance. But compared to the native Singaporean, the non-native Singaporean has a significantly higher proportion of antibiotic strain, especially clarithromycin, metronidazole, and multi-drug resistant, up to 40%. And this study also showed that the non-native was significantly more likely to fail the first-line eradication rate compared to the native Singaporean. So this slide to show that in real life practice, we also need to consider the origin of the patient to decide the appropriate empiric treatment. Now I talked about the situation of Myanmar, and you see in Myanmar you still have still high, a little bit higher rate compared to before 2015, but still less than 15% when we still have a low rate of amoxicillin. And we have a very interesting study. This is the randomized open-label randomized control trial comparing concomitant control therapy with sequential therapy. And in the first arm, they used the concomitant control therapy in 14 days, including brabeprazole, clarithromycin, amoxicillin, and tinidazole. And in arm 2 is the sequential therapy in only 10 days. And for the first phase, they used amoxicillin and brabeprazole, both in 5 days, and followed by clarithromycin, tinidazole, and brabeprazole twice daily for 10 days. This is a very interesting finding, which show that between the two, whether we use the intention to treat analysis of the per protocol analysis, there's no significant difference in the eradication rates. And more interestingly, this study showed that the cost per course of the concomitant therapy you see here is more than double compared to the sequential therapy. And again, it's a longer duration and a much higher number of pills. So it showed that in Myanmar, the sequential therapy is still a very effective and very cost-effective treatment for patients in Myanmar. So next, I would like to talk about the situation of Cambodia and Vietnam, the country with very high clarithromycin resistant rate. And this slide to show some local study in Vietnam between in the year 2010 to 2016 using the tripotherapy, and it has been shown that the eradication rate of this treatment has been failed significantly, and is no more recommended to be used as a first-line treatment in Vietnam. So now we use quadrotherapy and levofloxacin-based tripotherapy. And this slide to show you that open-label randomized control trial that comparing the quadrotherapy and levofloxacin-based tripotherapy. And this slide shows that in the group with use of quadrotherapy, when we consider the ITT of per protocol analysis, is also show that the quadrotherapy is much more effective compared to the levofloxacin-based tripotherapy. As I mentioned before, that in Asian country with high rate of clarithromycin, Bismuth is more popular, and we can find the Bismuth. And recently, we have some studies showing that the role of Bismuth may improve the eradication rate in patient use of tripotherapy. And this slide to show that when we compare the two treatments, tripotherapy without or with Bismuth, here you see bismuth is in black bar. If the bacteria is susceptible to levofloxacin, there's no significant difference. But if the bacteria is resistant to levofloxacin, then when we use the bismuth, we can improve and we can overcome the levofloxacin resistance. For example, in Vietnam, we have the levofloxacin resistance rate is around 40. So this is the eradication without bismuth. But when we use the levofloxacin-based tripotherapy, we can gain a little bit more than 80% of successful rate. And this also has been demonstrated in some case study in Vietnam that when we use levofloxacin-based tripotherapy without bismuth, this is the eradication rate. And if we use the bismuth combined with this treatment, this is the eradication rate. Because there's no randomized control trial, I think that the evidence is weak, but it's also show that when we have a bismuth, it may be more likely to be more effective when we use the bismuth combined with this treatment. And therefore, I would like to share with you some of the information in Vietnam that this year we have just finished the consensus of the Vietnamese Society of Gastroenterology on H. pylori management. And the first line treatment of choice is the quadrupole P here is for PPI, bismuth, metronidazole, and tetracycline. And the alternative treatment is the PPI, amok, levofloxacin, and bismuth. And the second line treatment, if we fail, then we change from quadrotherapy to the levofloxacin-based tripotherapy plus bismuth. And for this one, we use the quadrotherapy. And after 2 times of treatment and still fail, we need to use the microbial susceptibility testing. And we have also mentioned about PCAP, and PCAP has been already mentioned that it's available in some country in Asia, especially with in country with low rate of clarithromycin. And I would like to share with you some interesting information from DDW, and this is a meta-analysis from Professor Monthira and his team. And they try to compare the PCAP-based tripotherapy with other therapy. And here they compare with lansoprazole-based clarithromycin tripotherapy. And you see here that in our country, this vonoprazan-based tripotherapy shows superior efficacy compared to even with quadrotherapy, or you see here that tripotherapy. And it's also true for Western country. You see here that this is also the very good finding to show that vonoprazan-based tripotherapy is the most effective treatment compared to other available regimen. So I want to ask to mention about some evidence in our region. And this is the open-label randomized control trial comparing 7-day vonoprazan-based tripotherapy versus the PPI-based tripotherapy in 14 days in Thailand. And this is a non-inferior study. And in this study, you see here the white bar is for vonoprazan-based tripotherapy, and the gray bar is for PPI-based tripotherapy. So both intention to treat and per protocol analysis show that there's no significant difference between the two treatments. So if we use vonoprazan, we can shorten the duration by half. And similarly, we have another clinical trial with 7-day vonoprazan-based tripotherapy versus the 14-day PPI-based tripotherapy in Singapore. And here we randomize patients into 4 groups with omeprazole-based, esomeprazole-based, rabeprazole-based, or vonoprazan-based. And for the PCAP, they use only 7 days compared to 14 days in the PPI-based group. And in this slide, you see here that the red bar is the vonoprazan-based tripotherapy, and the blue bar is the PPI-based. So both intention to treat and per protocol analysis also show that there were no significant difference between the two treatments. And again, when the author compare the patient in the clarithromycin susceptible strain or clarithromycin resistant strain, there's also no significant difference, which show again that support the treatment, the finding in Thailand that PCAP in using in 7 days as a triple therapy can be an alternative choice in our region. So for conclusion, Mr. Chairman, ladies and gentlemen, regarding the trend of primary antibiotic resistance of H. pylori in Asian, I would like to mention that clarithromycin has been shown that some Asian countries are now at the borderline level. That means around 50% and maybe enter the high level in near future, which includes Malaysia, Singapore, and Thailand. And for amoxicillin, still the resistance is still stable or lowly increased, but has been increased alarming in Indonesia and Vietnam. For tetracycline, almost no resistance, but for levofloxacin, it has been shown to rapidly increase over all Asian countries. And we also have to face with the very challenging issue that we have a high rate of multi-drug resistant H. pylori strain, and especially alarming in Vietnam and in Cambodia. And regarding the low the treatment regimen for the low clarithromycin resistant region, it has been shown that triple therapy is still a good option, given that 14-day regimen is prescribed. And the sequential therapy has been shown to be a cost-effective option in Myanmar. And 7-day vonoprazan-based triple therapy has been shown to be non-inferior compared to 14-day PPI-based triple therapy, especially in Thailand and in Singapore. And for the high clarithromycin resistant region, it has been shown that mixed meal quadruple therapy regimen is a good option. And PPI plus amok, levofloxacin, and mixed meal regimen has been shown to be a good alternative option. And I think that the Bangkok consensus has been shown to be a useful tool for daily practice in about 1/3 of participants in our country, especially higher efficacy in in country with low clarithromycin resistant rate. And I think that the development of updated consensus is an urgent need for our region. So I would like to thank the organizer for inviting me to chair this meeting. And before ending my talk, I would like to again inform you about the survey on real-life practice of H. pylori eradication in Asian. And this is an ongoing project, and we wish very much to hear your voice. So please try it by scanning this QR code and answer this 5-minute survey. You may already have some invitation by email and provided the link from your colleagues in your country. Thank you very much for your listening.
Thank you so much, Duc, for your excellent talk. And I believe that in your surveys in ASEAN about the HP treatment is going to be very helpful for management of this important bacteria very soon. And before we go to the questions and answers, I'd like to invite Professor Monthira to sit beside me for a Q&A. Do you have any questions on the floor? I'm going to start first with Professor Monthira. I believe that we know the anti-acid medicines very well, such as the PPI. And right now, if you come to the PubMed, you can see the side effect of the PPI is a lot, maybe just like a chronic kidney disease, a fracture. Somehow, you think that the new mucoprotective agents, there might have been some more indications for treat instead of PPI in which condition?
So, Professor Ratha-korn said that we know a lot about long-term side effect of PPI. So, but in some cases that we could not avoid the GI injury, for example, long-term NSAID and aspirin, for example, we don't have much data in that patients. And I think mucoprotective is one that we is interesting because it has local effect. It's not a systemic effect. So if we have more data in terms of prevention, especially in aspirin-induced enteropathy, it should be better for patients to avoid the side effect, long-term side effect of PPI.
So, Professor Sukano, please.
Yes, I have some comment to the first speakers because we have done a couple of long-term NSAID prevention study, either with lansoprazole, esomeprazole, and vonoprazan for 6 months to 2 years. And during that period, we didn't see any, harmful event occurring in the mid-GI or lower GI in terms of reduced hemoglobin levels or ulcer, bleedings. I think the capsular endoscopy studies, they show the increased, mucosal injury, but they are all subclinical in a sense. And so we didn't see much concern on the safety profile of long-term use of PPI to prevent ulcer relapse, especially for the upper GI ulcer relapse. So that's my comment. So in the long run, I think there are some recovery or adaptation process ongoing, and so, as you can show us, you could show us one slide that shows some reduced, mucosal injury level. So that's my first comment. So at least the small bowel injury during the course of long-term PPI or even PCAPs, it might not be a clinically relevant, I think, adverse event in terms of the major bleeding or dyspepsia, etc. So that's my first comment. My second comment is that currently the best evidence for preventing end-stage injury in mid-GI or lower GI is reported by Taha's groups using low-dose misoprostol, which was published in Lancet. So the ursogliding study should be compared with the low-dose misoprostol in terms of the comparative efficacy. That's my second comment.
Thank you for your comments. Just one concern about the misoprostol. Sometimes they have some side effect, right? Just like nausea, vomitings. But I believe, same as your thought, that it might be one of the important meds that we can use for some kinds of a specific condition.
You can use a low dose of misoprostol, which doesn't have any significant adverse event to reduce the small bowel injury.
Thanks. So, Professor, Monthira, you have
Actually,
any
I
more
know that
comments?
I'm supposed to be the one who answered the question, but if I can ask your Professor Sugano, because you're in Japan, you are Japanese and mucoprotective agent, most of them came from Japan. Do you have any experience and any suggestion for, in terms of choosing mucoprotective agents?
One esomeprazole prevention trial involved not only Japanese, but also Korean and Taiwanese. So it's multinational prevention trials. So in that sense, I think PPI can be used safely for preventing recurrence of peptic ulcers for long term.
Thank you. So for Professor Duc, now they have a new challenge for the treatments of H. pylori by using just like an antibiotic susceptibility test. We call it Taylor therapy. Well, the very first before we start the treatment, just like we use the stool for DNA sequencing. So how about your thinking right now? So do you support the ideas, or we should go to the empirical treatments as a guideline say?
Thank you, Professor Ratha-korn. I think that's a very interesting question. The COVID-19 has been very dangerous, but there also give us some change that now PCR, the equipment is now available more common in Vietnamese hospital, and I think that it might be similar situation in other Asian countries. And I think that it's a good point that we use the susceptible test to guide the treatment before we use the before you use the first line regimen. But I also would like to share with you one interesting finding in our study that we recently we have open label randomized control trial comparing between quadruple therapy and what we call the Taylor therapy, and it has been shown that if the patient use the quadruple therapy, empiric therapy in Vietnam, with the country with high level of resistance of clarithromycin and amoxicillin and metronidazole as well. So comparing between the two arms, we still see the significantly higher eradication with the patient using empiric treatment. So for the Vietnamese situation, we recommend our colleagues in our country to use the empiric quadrotherapy first. And if we fail the treatment, then we consider the susceptibility testing. And in this case, I think that PCR is a good choice.
Thank you so much. I believe that we got a very good talk together and very good discussions. And because of the times, I'd like to close this session and would like to thank you, the Farmaline and Meiji company for make these sessions possible. Please make big hands for these two companies.